Hi, this is Julian Goldman presenting quantum clinical scenario number 4, increasing levels of interoperability of medical devices, and we're using as a framework for that discussion the clinical scenario of sedation of a patient for a gastrointestinal endoscopy procedure, such as a colonoscopy. Let's discuss for a moment the notion of increasing levels of interoperability of medical devices, which we've called our FDA PRS, or Prototype Regulatory Submission scenario. The background is that for a number of years, we've recognized that the analysis of the implications of interoperability from a system safety standpoint requires a deconstruction of an interoperable system into smaller elements and a deeper understanding of the strengths and weaknesses, that is, the risks and the benefits of the system in clinical use. For example, typically today we manage patients with standalone medical devices, a separate intravenous infusion pump, separate monitor, a separate pulse oximeter, or maybe a multi-parameter monitor which includes a pulse oximeter, an EKG, and other things such as that. Now, these devices today work quite well, but they work independently. Therefore, you can't use the intelligence of the environment to optimize the use of these devices in the care of a patient. Therefore, unfortunately, we have incidents where all of the devices worked well, everything functioned as expected, but the patient had an adverse outcome. For example, the patient may have an overdose or receive an overdose of an intravenous medication used for sedation, even though the patient is also being monitored with pulse oximetry and a respiratory rate monitor. So one would ask, if we're monitoring all of those things, why can't we use that information to optimize the delivery of the medication? Similarly, we have separate devices with separate screens, each in a different location. What if we need to combine that data so that we could more easily look at the data in one central location from different devices? Or perhaps we want to combine the data from multiple devices to create more intelligent, more useful, more reliable alarms. So with that kind of general idea and that framework and understanding that we needed to dig deeper into the hazards and their mitigation when developing interoperable systems and assembling them or assembling the components of those systems at the point of care, a number of us, individuals as well as organizations, joined together for an FDA workshop in January of 2010. And that workshop was coordinated by the Continua Health Alliance, by CIMMYT, the Center for Integration of Medicine and Innovative Technology, and of course the FDA, and held at the FDA as a public workshop. Following the workshop, the insights and discussions from the workshop were continued with an interdisciplinary team that formed the FDA Prototype Regulatory Submission Working Group. And our goal was to analyze the hazards of and the risk mitigation strategies for interoperable medical device systems in order to inform future regulatory approaches. We called it a prototype regulatory submission because our goal was to create a educational or research regulatory submission with research devices and potentially devices on the market. And this is in stark contrast to a typical regulatory submission in which devices that are ready to be marketed are presented to the FDA for clearance to market those devices for use. As part of the work, our PRS working group produced a levels of interoperability analysis to align the risk with the complexity and clinical function of the system. And the following scenario is an implementation of that analysis. We're using this scenario within the context of our quantum medical device interoperability work to further address the risk mitigation strategies for interoperable medical devices. This is a screenshot from the FDA website of the workshop in January of 2010. It was a 2.5-day workshop, and transcripts are available for download from the FDA website. So let's go through the scenario. Again, the clinical setting is sedation for GI endoscopy. So the first level of complexity, of risk for interoperability is the notion of the creation of a virtual display. In this setting, the data from a pulse oximeter, from a capnograph, an end-tidal CO2 monitor, and from a depth of anesthesia monitor. A BIS is one brand and type of a depth of anesthesia monitor, which uses an electrode on the head, an EEG electrode, processes that data and indicates the depth of sedation with a single number. The data from those devices are remotely displayed to a display that's perhaps on the other side of a room, and in order to facilitate viewing of that display during the colonoscopy. The interoperability aspect of this scenario is the notion that the devices are capable of being exchanged as needed. So perhaps we want to swap one pulse oximeter with a certain set of capabilities for a different pulse oximeter. And when we do that, because the devices are interoperable, we will continue to have the data displayed on that virtual display across the procedure room. The second level of the scenario is one in which we use derived alarms. So in this case, we would take data from the pulse oximeter, from the end-tidal CO2 monitor, and from the depth of sedation monitor, and combine that data in such a way that we could create a smart alarm to provide earlier detection of medication-induced respiratory depression during the procedure. So again, this is a patient who's undergoing colonoscopy, receiving an intravenous medication for sedation. It's typical that if there's a relative overdose of medication, or even if there isn't an overdose, it's just an effect of medication to cause respiratory depression. That is a decrease in respiratory rate and a decrease in the size of a breath or the tidal volume. And if these things happen, if the patient has respiratory depression, we want to detect that and reduce the medication dose that's being administered so that the respiratory depression does not lead to respiratory arrest, to cessation of breathing, which could, if untreated, lead to a cardiac arrest. So again, in number 2, we are developing derived alarms using data from multiple monitors, using a number of techniques that have been widely published to perform what sometimes is called sensor fusion, or other types of decision support approaches to have earlier detection, a smart alarm with better sensitivity and specificity to detect respiratory depression. In the third scenario, we're introducing the idea of a virtual front panel or remote configuration of the device. For example, if the patient is receiving their intravenous sedation medication, perhaps propofol, with an infusion pump, it isn't unusual to have the pump situated in the room at a distance from the patient or location where it's actually difficult to reach that pump, and to make a medication adjustment change to change the infusion rate. Typically, in treatment rooms are cramped environments. There are, in this case, gastroenterologists performing the procedure. There are assistants, maybe students, nurses, and members of the anesthesia team. Hard to say. There are many ways in which the procedure is performed, but in general, we're dealing with a cramped environment, and it can be physically difficult to access the infusion pump. Why not make that more convenient? Why not improve workflow in order to allow access and control of the device from a more central location that's closer to the personnel? The fourth level in this scenario is autonomous control. And in this case, we're now using the signals from the various physiological monitors to improve the safety of administration of medication through a safety interlock. So, for example, we could use a decision support algorithm running on the ICE supervisor to stop the intravenous propofol pump if the respiratory rate drops below a certain threshold value, or if the blood pressure drops below a certain value, or a number of other, perhaps combination of these events. Again, the notion of number 2, the derived alarms, so data fusion, to implement a safety interlock. Or perhaps one level of increasing level of sophistication here would be the implementation of physiologic closed-loop control. That is, instead of only stopping the infusion with a safety interlock, one would restart the infusion and titrate or adjust the infusion rate of the sedative medication to achieve a target value, perhaps on the depth of sedation monitor. So that's a description of the 4 discrete levels of interoperability from a risk standpoint, a complexity standpoint. And as part of this scenario for Quantum Medical Device Interoperability Project, we will be elaborating on the risk mitigation strategies for each of these scenarios. And this will help direct the development of our technology solutions and other work products to enable this type of levels, these types of levels rather, and we will be feeding this information into the pre-IDE project that's underway with the FDA. If you have any questions about this or related work, please visit our website at www.mdpnp.org. Thank you.